Hi.
Hello, Sudarshan sir, welcome.
Hey, hi. You're
Hello, sir,
offline.
welcome. We are on time.
We are offline.
We are not offline.
Okay. Just check. Working, no?
Yeah.
How are you all?
Okay. All good. JB sir, you want to try sharing screen?
Yeah, that's what I'm trying.
Hi, Sudarshan.
The voice only is heard. Hi. Busy, yes, Sapnesh. Handing around so many people, so many sessions.
JB sir is on the retina side.
Okay.
NTV madam just finished.
Hi Sudarshan, how are you?
Okay, I have opened the slides. Should I minimize it?
No, sir.
JB is trying, I think. Jyotirmay Biswas.
Sir, you click the up arrow.
That's why I said
and-
I will wait. Because next
I
session is
close it. I'll please click the red button.
No.
Probably Salil Mehta has not closed it.
Green up.
Yeah. Okay.
I checked it. No, it worked. I think like he's closed.
Yes.
How do you zoom it? How do you go back to the Zoom? Swapnesh?
Yes, sir.
How do you
I
go
think
back?
no,
I'm
somebody else has logged in.
Myself,
Rajit Majid.
Dr. Ajit Babu. Yeah.
Sir,
I will stop it.
no problem. JB sir was trying to share his screen.
Yeah, I stopped it.
Yeah.
I think I told Sai he will help JB.
Okay, Shai is the
Will call you.
Shai.
I just wanted to check whether mine is working or not. That's it. It's done.
I am not able to come to the Zoom platform.
No. You go to this share screen. There is a green button is
No,
there.
that's not coming.
It will come. Once you go down with your
No,
arrow on the desktop,
yeah.
then all the
Hello?
logos will.
Yeah. No. I just don't find the green button is there. Blue button is there. Blue Zoom symbol.
Good afternoon, everyone. It's 2:15. Can we start with the next session?
Samyak, I think you should start.
All right. So, welcome all. I welcome everyone on behalf of Bombay Ophthalmology Society and MOS for the virtual symposium. This is uveitis session part 2. I would like to first welcome Dr. Biswas, he actually needs no introduction. He's the head of uveitis and ocular pathology at Shankar Netralaya. And a special congratulates to him because he's been conferred the prestigious B.K. Narayan Rao Award very recently from the All India Ophthalmology Society in 2021. And he's a well-deserved, he's one of the best teachers and great researchers. He will be the chairman of the session. I also welcome our co-chairman, Dr. Nikhil Gokhale, who's a cornea specialist from Mumbai and also manages uveitis, especially scleritis. Our convener today is Dr. Mayur Morekar. Co-convener is Dr. Hitesh Sharma. I would ask our first speaker, Dr. Swapnil Parchand, to start sharing his screen. Dr. Swapnil Parchand, he is a consultant in retina and uveitis services at the MGM Eye Institute in Raipur. His area of interests is diabetic retinopathy of prematurity, and uveitis.
Thanks
Dr.
a lot.
Swapnil, you can start.
Yeah, thanks a lot, Dr. Samyak. My screen is visible.
Yes,
Yes, it is visible.
I thank BOA for giving me this opportunity. So the topic of my presentation is sympathetic ophthalmia. So let's go back to history. So the first description of sympathetic ophthalmia was given by Hippocrates in 1000 AD, and he stated that the right eye when diseased often gives suffering to the left. Following that, in 16th century, Bartist wrote that after the injury in one eye, the other good eye is in great danger. Following that, in 1830, William Mackenzie coined the term sympathetic ophthalmia, and Fuchs and Dellen, they described Dellen-Fuchs nodule as inflammatory nodular aggregates. Basically, sympathetic ophthalmia is a bilateral diffuse granulomatous panuveitis that occurs after trauma or surgery in one or both eye. Injured eye we call as exciting eye, and the fellow eye we call as sympathizing eye. So epidemiology, it is quite a rare disease, but we actually don't know the true incidence because many of the milder form of the cases may get undiagnosed. Gas was the first to report the prevalence of sympathetic ophthalmitis. He reported that following penetrating eye injury, the incidence or prevalence was around 0.06%, and it was 0.01% following pars plana vitrectomy. Following this, many articles reported the incidence as 0.2 to 0.5% following penetrating ocular injury, and following ocular surgery, it was reported as 0.01%. Sympathetic ophthalmia is more seen in males and children because they are more prone to the ocular trauma. Coming to etiology, most of the time it is reported after penetrating trauma. There are reports of sympathetic ophthalmia developing after ocular surgeries that includes pars plana vitrectomy, cataract surgery, glaucoma filtration procedure, scleral buckling, evisceration, even after paracentesis, iridectomy, or laser cyclophotocoagulation, or proton beam irradiation for choroidal melanoma. So basically, most of the cases present between 2 to 6 weeks of ocular trauma. But there are isolated reports that it can present as early as first week or as late as 66 years after the initial injury. 80% of the cases of sympathetic ophthalmia present within 3 months of ocular trauma, whereas 90% present within 1 year of ocular trauma. So coming to clinical features, most common presenting symptom is decreased vision or floaters. patients may also present with pain, watering, or photophobia. On presentation, they have anterior segment inflammation. It can be initially non-granulomatous anterior uveitis, but if left untreated, they develop granulomatous uveitis, and we can also see mutton fat keratic precipitates, as we can see here. Conjunctival injection, iritis, osseous synechia, peripheral anterior synechia. IOP can be low or it can be high. Posterior segment manifestation include vitritis. Many of the cases might just have few retrolental cells and disc hyperemia or disc edema to begin with. So it is important to see retrolental area for presence of cells. So vitritis and papillitis are the most common features. And then we can see this yellowish white choroidal lesions, which are called as Dallenflex nodules. And it may be associated with exudative retinal detachment over the posterior pole or inferiorly. In chronic cases, we can see extensive chorioretinal scarring, sunset glow fundus, macular scar, or we can see such lesions which we call as nummular chorioretinal scar in inferior periphery. Coming to pathogenesis, once there is ocular trauma, this causes exposure of uveal retinal antigens to conjunctival lymphatics. These uveoretinal antigens are basically choroidal melanocytes, uveal pigments, retinal S antigen, interphotoreceptor retinoid binding protein, melanin associated antigen. And this induces what we call as immunopathological response, that is cell mediated autoimmunity. There is also genetic predisposition for this disease. So coming to pathology, basically what we see on histopathology is diffuse granulomatous, non-necrotizing inflammatory cells predominating lymphocytes, and which is infiltration of choroid. Dallenflex nodules are basically clusters of epithelioid cells containing pigments located between RP and Bruch's membrane. And importantly, there is an absence of inflammatory involvement of choriopapillaries and retina. So diagnosis is basically based on history and clinical examination. Differential diagnosis, mainly we have to differentiate between VKH. Other differential diagnosis includes sarcoidosis, tuberculosis, syphilis, traumatic or post-operative endophthalmitis, or intraocular lymphoma. But this can be differentiated easily based on history, clinical examination, and ancillary investigation. So if we have to differentiate it between sympathetic ophthalmia and VKH, so sympathetic ophthalmia can occur in all ages, whereas VKH is usually seen in middle-aged people. Racial predisposition is none for sympathetic ophthalmia, whereas VKH is mostly seen in Asian or Black population. Penetrating trauma or history of surgery is always present in sympathetic ophthalmia, whereas it is absent in VKH. Skin changes, CNS finding, hearing dysfunction is commonly seen in VKH, but it is uncommon in sympathetic ophthalmia. Again, serous retinal detachment is frequently seen in VKH, but it can also be seen in sympathetic ophthalmia. Choriocapillary involvement it is frequently seen in VKH, but it is usually absent in sympathetic ophthalmia. And on CSF analysis, it shows pleocytosis in VKH disease, whereas it is normal in sympathetic ophthalmia. So coming to investigation includes FFA, ICG, B-scan, and optical coherence topography. So in FFA, we see usually in early phase, we say pinpoint hyperfluorescent area, which progressively increase in hyperfluorescence over a progress of FFA. And in late stage, there is pooling of dye in the area corresponding to exudative retinal detachment. Sometimes we can see in early phase, we can see this hypofluorescent area, which actually turns in hyperfluorescent pinpoint area. And again, there is progressive leakage of dye and pooling of dye in the area of exudative retinal detachment. Coming to ICG, ICG in intermediate phase, basically we get two patterns on ICG. In both the pattern in intermediate phase, we see hypofluorescent, but whether hypo turns into hypo or hypo turns into iso, we need to see, because basically it tells us whether there is full thickness stromal granuloma or partial thickness stromal granuloma. If it is hypo, staying hypo, it tells us that it is full thickness stromal granuloma. But if it is hypo turning into iso, then it is partial thickness stromal granuloma. So in this, we can see that it is turning into isofluorescence on late phase. So it is partial thickness granuloma, whereas it is remaining hypofluorescent. So it is full thickness choroidal granuloma. On B scan is basically for documentation of choroidal thickness. Usually anything more than 2 mm on B scan is considered as significant choroidal thickening. We can actually do on follow-up to see the effect of oral steroid or treatment. Choroidal thickness can also be done nowadays on EDI on OCT. And again, OCT will also show the RP undulations, exudative retinal detachment, and it can also quantify the choroidal thickness. Coming to treatment, we need to treat case of sympathetic ophthalmia quite aggressively. In case of very severe inflammation, we might have to give IV methylprednisolone 1 gram for at least 3 days loading dose. Following that, we have to shift on oral steroids 1 to 1.5 mg per kg per day, and it should be very slowly tapered over a period of 4 to 6 months. And then following that, we might have to keep them on maintenance dose, that is 5 mg or 7.5 mg for longer period of time. Apart from this, these cases also require topical corticosteroid and cycloplegics to treat anterior segment inflammation. And in some cases, we might also give periocular steroid to control the recurrences and CME. Now, there is a very important role in corticosteroid sparing agents, because most of this patient have severe inflammation and they goes on to develop recurrence of disease frequently. So we need to give them corticosteroid agents that includes azathioprine, mycophenolate, cyclosporine, chlorambucil, or cyclophosphamide. Most of the time, I personally use azathioprine or mycophenolate. Advantage of azathioprine is it has, of course, it has side effects, but it is less toxic. It is easily available. It is quite cheap as compared to other immunosuppressive agents. Mycophenolate, again, it is quite it quite nicely controls the inflammation. Only thing is it is quite expensive as compared to azathioprine. So surgical treatment, role of prophylactic enucleation. Basically, the role of prophylactic enucleation is there only if it is performed within 2 weeks of penetrating injury, but this is now past. Now, most of the time we don't need to enucleate because we know how to close the wound properly. So it is no longer advised. Only in certain cases where the eye is quite shattered, we cannot remove the uveal tissue that is prolapsed adequately, or if the eye was already blind and then over that patient has developed open globe injury, in that cases only we can consider prophylactic enucleation. Sometimes the eye which we see that has trauma is quite bad, but on follow-up when we repair them and do subsequent surgery for visual rehabilitation, this eye might turn up having better vision as compared to other eye. So always attempt should be made to repair the wound, and following that the decision for enucleation to do or not can be done later on. And of course, surgery can be done for other complications like glaucoma or complicated cataract. Complication of sympathetic ophthalmia, what we see can be secondary glaucoma, cataract, or a chronic maculopathy, choroidal neovascular membrane, optic atrophy, and phthisis bulbi. Nowadays, prognosis is good because we know how to treat it aggressively. We know we are better experienced with immunosuppressive agents. Only poor, in some cases we can see poor visual prognosis if there is presence of glaucoma, macular scarring, or persistent inflammation. Relapse is quite common, so we need to keep them on long-term immunosuppressive agents, and long-term follow-up is necessary. So we have seen some changing trends from in sympathetic ophthalmia. So in past, maybe before 20 years, if we need to see, so the most common cause was post-trauma. Again, males and children were most commonly affected. Then later on, it was seen that sympathetic ophthalmia is disappearing. Onset is again within 2 to 8 weeks. Usually the presentation is granulomatous panuveitis. In past, people used to enucleate the globe within 2 weeks of trauma, and visual acuity or visual outcome was poor. Now, currently, most common cause is post-surgery, especially vitreoretinal surgery. There is especially no genetic preference and usually seen in elderly patients. Incidence is maybe probably increasing, but we are underdiagnosing them, maybe milder form of disease. Onset might be delayed in post-surgery. Presentation, it can present as just anterior segment inflammation or just lateral lentil cell papillitis, or it can present with full-blown sympathetic ophthalmia with exudative retinal detachment. Nowadays, primary enucleation is questionable, and the visual prognosis is relatively good with immunosuppressive drugs. So the key point from this presentation is sympathetic ophthalmia is no longer a blinding disease. Diagnosis is usually made clinical. It can present with diverse clinical form. High index of suspicion is quite important, and with early recognition and appropriate control of inflammation, we can properly manage this case with good outcome. Regular follow-up is important, and we have to monitor patients for side effects and complication for their treatment. Thank you so much for your patient hearing.
Thank you, Dr. Swapnil. Wonderful presentation and very good key takeaway points. We shall take the questions in the end. Meanwhile, I would like to invite our next speaker, Dr. Nikhil Beke, to please start sharing the screen. Dr. Nikhil is a practicing vitreoretinal surgeon and a uveitis expert from Pune. He's
Can I
received
make some comments about the sympathetic ophthalmia?
Yes, sir.
So as sympathetic ophthalmia, the diagnosis is less challenging. The reason is that history is so pertinent and so easily available that one eye injury is there. The challenge is in the management of these cases. Even the diagnosis part of it, imaging and all these things, can help it substantiate it. The management is, as has been told, is intravenous methylprednisolone. There is no doubt about it, followed by the oral steroid with immunosuppressive agents. But in the stepwise pattern, we start with the azathioprine and mycophenolate mofetil. If it doesn't respond, you go to the cyclophosphamide, or if it doesn't respond, you go to the cyclosporine or triple agent immunosuppressive therapy. And recent literature shows that even biologics like adalimumab, which can help. It can reduce the dose of steroid, which is maybe a lot of problem in the long-term side effects are there. So the biologics has also emerged as a helping hand, provided a helping hand in the treatment of the sympathetic ophthalmia. So I want to highlight that this is the patients having one eye only, and so we need to be very aggressive in treatment. Okay.
That's right, sir.
Thank
Yes.
you.
Yes, sir. So we will start with Dr. Nikhil now. He's a practicing vitreoretinal surgery and uveitis expert from Pune. He's trained in PGI Chandigarh and is presently attached to HV Desai Hospital and Dinanath Mangeshkar Hospital. Dr. Nikhil, please.
Hello. Many thanks to PU and MOS for the opportunity. Is my screen visible?
Yes, it is visible.
Yeah. So the purpose of carrying out imaging in uveitis is timely diagnosis, monitoring for treatment response, and early pickup of complications. So we basically aim at studying the anatomy of the disease, where we are trying to visualize the structures, or we might be trying to pick up the inflammation in its early stages, or the activity of the inflammation, carrying out angiographies. So the fundus photography is the easiest of the imaging techniques, which is the most widely available imaging technique, and doesn't really require any kind of special skills to learn or perform the skills. And very easily trained, very well trained optometrists can help with these images. And what's important is not just snapshot of these images, in the sense they have to be carried out on a serial basis for documentation and for picking up progression or regression of the disorders. So this helps in such situations where the patient has a multifocal distribution of tiny lesions, and the patient relatively is preserving good vision over a period of few years. And you can see the progression of disease merely because you are able to compare it with the past images. Otherwise, in terms of patient's visual acuity and visual function, the patient remains status quo. And in this particular case, the serial imaging helped suspect recurrence, and angiography confirmed it. It can also be used with a standardized flash settings and done by an experienced photographer. Done over a period of time, can be able to, you are able to document the vitreous haze, which can be used both for clinical purposes as well as for research purposes. And this is the semi-quantitative grading of vitreous haze, which can be applied in our clinical scenarios as well. And obviously, like everywhere else in ophthalmology, the images basically pave the way for further analytics. This helps you subject these images to artificial intelligence, and probably such programs would be evolving in future. The fundus fluorescein angiography is the next easily available technique, and it helps us differentiate very easily in this context. Helps us differentiate between retinitis and choroiditis and reach an accurate diagnosis. So in the left side images, the top image is the early image and the bottom image is the late image. So what you can see is the pitch black lesion, which shows hypofluorescence at the level of retina as well as at the level of choriocapillaris because of the blockage. And in the late phases, you can see the perilesional capillaries staining and leaking very profusely, but the lesion stays rather hypofluorescent. On the other hand, vis-a-vis that, in choroiditis, you get initial hypofluorescence, but the retinal vasculature is perfectly intact overlying the lesion. And in the late stages, you see these lesions lighting up, causing late hyperfluorescence. So in cases of VKH or sympathetic ophthalmia, it's very easy to see multifocal distribution choroidal granulomas and late stage pooling of dye in the late FFA phases. And this would obviously be more helpful with retinal vasculitis cases being a vascular entity, would show in non-occlusive vasculitis, it would show the vascular leakages and the block fluorescence because of the hemorrhages brilliantly. But it also helps in non-occlusive capillaritis, as would be the case with Behçet's disease and intermediate uveitis, where the otherwise signs of occlusion such as retinal hemorrhages and sheathing won't be visible. FFA would be very helpful to pick up an early recurrence. And vasculitis complications can also be picked up very effectively on FFA, such as cystoid macular edema, capillary dropouts, and neovascularization. It can also help you pick up the choroidal non-perfusion areas and associated ischemic optic neuropathy in this context, the arteritic optic neuritis in cases of polyarteritis nodosa. And with the advent of wide field angiography, you can document all the lesions which are there in the periphery and even see the treatment response, as is the case with IR1, and treatment response to peripheral selective scatter laser photocoagulation. So the indocyanine green angiography is less available and requires quite an expertise, has a learning curve to understand the pathology and to be able to correctly diagnose it. And in the era of currently OCT angiography and other angiographies available, this is almost like a test cricket in the area of T20. And there are editorials which are being published which question whether it's still relevant. Fortunately, uveitis happens to be one scenario where it's extremely relevant. And it's basically because of the dye being protein bound, you can get a very good resolution of the choriocapillaris looking across the filter of RPE. And this is a case of choroidal granuloma. You can see in the rightmost image, you can see the dense choroidal granuloma, which is compressing on the choriocapillaris. And similar is the picture, which shows an hyposyanescent dark dot overlying the granuloma. This is the only imaging technique so far, barring OCT angiography, which helps you quantify the choroidal ischemia and help us govern the decisions, such as whether to start immunosuppression for this particular patient of white dot syndrome. And the optical coherence tomography is becoming increasingly more available to retina as well as uveitis experts. And we need to know the entire anatomy of the retina and choriocapillaris and the vitreoretinal interface. The cystoid macular edema is the commonest indication. You can see the treatment response and it correlates with the functional response that one gets to, let's say, in this case, Ozurdex. It can also help us diagnose the foveal traction. And it can also help us image the choroid in a better way with either enhanced depth imaging or with web source imaging, which the morphometric measurements can help you identify an early recurrence even before the fluid comes up. It can help you identify an early recurrence of sympathetic ophthalmia or VKH. And it can also help you monitor the response to the treatment, as in the choroidal thickness getting thinner in this case. And OCT angiography is the next extension, which is also getting widely available. What we need to understand is there are three kinds of vascular complexes within the retina: the superficial, intermediate, and deep capillary plexus, and the choriocapillaris. And this is an exemplary use of OCT angiography in this case, which was misdiagnosed as a case of toxoplasma retinitis and was referred from outside. And the OCT angiography picked up a choroidal neovascular membrane at the level of the avascular zone between the outer plexiform layer and the RPE. And the OCT angiography becomes particularly important in choroidal neovascularization out of inflammatory causes because it's devoid of leakage. So the resolution stays and you are able to diagnose the disease better than what would be diagnosed on fluorescein angiography, and almost would have equivalent performance on ICG angiography. And this is another case where, despite of having no macular edema in the middle frame, still able to see the deep capillary plexus dropouts in the case of CNS SLE vasculitis, which explains the poor visual outcome in this case, even after the treatment of cystoid macular edema. So the fundus autofluorescence is basically lipofuscin mapping. So this indicates the areas where lipofuscin is concentrated, which corresponds with the areas which have ongoing inflammation. And the areas which are devoid of lipofuscin would be the areas where the inflammation has burnt out, leaving behind a RPE defect or a defunct RPE. So this is very easy to learn. So this is a patient coming to us with choroiditis. You can see hypoautofluorescent lesions just upper temporal to the fovea. And this is the lesions which are in the healing phase at a later follow-up. And this person came back with a recurrence, although asymptomatic. And the new lesions have cropped up upper nasal to the fovea this time. And you can see the white lesions in the sea of other black lesions in the vicinity. And this is the complete resolution of the lesions at the end of 2 years. So there have been multiple publications which have documented the stage-wise progression of tuberculous serpiginous-like choroiditis lesions from their early stage of inception to the final stage where the disease has burnt out. And ultrasonography happens to be the last imaging technique which is going to be widely used. So this not only helps in those cases where poor media, because of the poor media, the posterior segment visualization is rather difficult, but also helps in those cases with clear media, as in case of VKH or sympathetic ophthalmia, where the media is relatively clear, but it helps you with documentation of choroidal thickness. And it also helps you with presence or absence of T sign, the subtenon space fluid collection. So this is the common example where you have a prodrome, you have bilateral serous detachments, hypo to hyper dots on fundus fluorescein angiography. And then on ultrasound B scan, you can see a peripapillary thickening of retinochoroid. Along with serous retinal detachment, and this peripapillary thickening tapers out as you move towards the periphery. So this is the classical description of ultrasound P-scan and VKH or sympathetic ophthalmia, and this shows a rapid resolution with systemic spheroids. So when all these, I'm sorry for the loss of the image here because of problems with my phone, but when all these imaging techniques, the data procured from all these imaging techniques, when it's meshed together, what we are doing is increasing the sensitivity and specificity of the entire diagnostic process, because all the clues procured from each of these imaging techniques, they get put together and helps us narrow down the list of differential diagnosis and ultimately reach the correct diagnosis. Thank you.
May I make one comment?
Yes, sir.
May I make one comment? I find in my practical practice, clinical practice, the only one thing is very crucial for me to differentiate between the multiple CSR and that VKH or posterior scleritis. And then here the FFA helps us to really clinch the diagnosis. Subtle CME, subtle ERM, and the CNVM. These are the cases where I find the imaging is the most crucial for me to help me to the great extent. That's all I want to make.
Sir. Thank you. We shall move on to the next speaker. Dr. Hitesh, can you please introduce our next speaker? I think Dr. Hitesh is muted. I would like to introduce our next speaker, Dr. Sudarshan. He's a senior consultant, Department of Uveitis at Shankarnatralaya, Chennai, and he also is a treasurer in the Uveitis Society of India. Dr. Sudarshan, you can proceed. Thank you, sir.
Thank you. Can you hear?
Yes, sir.
First of all, thanks, Swapnesh and the BOA team for the opportunity. To start off, there'll be some amount of repetition probably compared to what was spoken in the previous session and now. And let's see uveitis. Maybe like I'll try to focus a little more on anterior uveitis than on posterior and retinochoroiditis. But when you see something like that, what comes to your mind? So each of us, like when you start looking at something, let it be uveitis or anything on the around in the surrounding or anything, we each of us imagine something. Something like this. When you see something like this, what do you think? You start imagining who is this. You might think of so many people. So you start looking at what do you. So you see if there is any similarity with the eyes, similarity with the way wear the head band or something like that, or the way they talk or what they talk and something like this. So uveitis is also like this. You look at the pattern, see if it matches any of the known patterns, see if there are some supportive evidence, see if there are some indicative subtle signs, and then make a diagnosis. So let's see a pattern recognition in uveitis. I'll try to see a clinical tips and a broad overview. We'll see how much we can diagnose with slit lamp alone or with indirect and slit lamp and with basic lab and ancillary investigations. So in uveitis, as I said, like you identify the pattern, see if it matches with the known patterns which have already been described and proven based on lab or ancillary investigations or biopsy. Look for some supportive evidence. Supportive evidence can be systemic or subtle ocular features which you'll have to pick up. So it's always important that you pay attention to detail. Sometimes it will be glaring at you, and when somebody points out to you, then you'll realize that, oh yeah, like this is what I've been looking at it for such a long time and I didn't pick it up. So investigate and confirm the diagnosis, or sometimes investigation or intraocular specimen evaluation will help rule out the masquerades. Treat based on the diagnosis. Most of the time, the patterns will give you clues for you to make the initial priority-wise differential diagnosis, towards which etiology you need to lean. So let's start with anterior uveitis. Look for the classical signs and symptoms, posterior segment clues or indicators, and systemic. See, the common one is the typical KPS presentation in the ALS triangle. This is not characteristic of any disease. This is a problem. This you need to start investigating only if you see it again and again, if it's recurrent. This doesn't give you any indication based on the pattern alone. So this is difficult to diagnose. But if you see some characteristic patterns like a fibrin or an organized coagulum or a hypopion, or if you have mutton fat KPs and the type of Seneca, the KPs, distribution of the KPs, associated IOP or iris changes, then you can really start thinking towards a diagnosis. For example, the classical one, if you have a organized fibrin, organized coagulum or a fibrin, then you are probably dealing with a case of a If this comes in a young adult in one eye especially, then you're probably dealing with a case of a HLA-B27 associated uveitis. So anytime you see a fibrinous non-granulomatous anterior uveitis presenting in a young adult, then you think of HLA-B27 associated uveitis. Ask for history of backache, skin lesions, and these are the 4 differential diagnoses commonly associated with this kind of presentation. But the more scary one is the hypopyon. When you see hypopyon, your antennas have to be up. You always think of infection first. I keep repeating this very often every time I present a hypopyon case. Hypopyon in my clinic will be Behçet's, in a VR clinic probably will be end off. But when do you decide which is, if it's Behçet's or end off? Look at the characteristic of hypopyon, the glow and associated complaints and all other things. So most important thing is if you have a transient and mobile hypopyon, then it's most probably not infective. Ask for history of aphthous or genital ulcers, then probably you're dealing with a case of a Behçet's. But look at this. If you have a hypopyon with an yellow glow, Dr. JB keeps telling us again and again every time, there will not be an yellow glow in a non-infective uveitis. So if you have an yellow glow and with hypopyon, you're probably dealing with an endophthalmitis. So if you have a convex thick hypopyon with a yellow glow, look at the fundus, and if you have organizing fluffy exudates, you're not dealing with uveitis. So if you have a fibrin or organized coagulum, it's probably HLA-B27 associated. But if you have a hypopyon, maybe it's Behçet's, but remember that it can be malignant or infective. The next pattern is the granulomatous uveitis presentation. If you have a granulomatous KP, look closely. This is a granulomatous uveitis presentation. Look close. Look at the synec. If you have a broad-based synec, large iris nodules, then you're probably dealing with the first DD in India obviously is tuberculosis. So in this case, only based on this alone, you may not be able to make a diagnosis. Look for posterior segment clues and indicators. Even if you have healed lesions, something like this, if you have a CRA adjacent to a vessel and with a granulomatous uveitis with broad-based synec, then you are expected to lean towards ocular TB. You may have active posterior segment presentations like a choroiditis or supposition-like choroiditis, then it's even more easier. But in the absence of any active lesions, even if there are healed lesions like this, then you can probably go in and investigate more for tuberculosis. If you have a granulomatous uveitis with angular KPs, then you're probably dealing with sarcoid. Look at the posterior segment, and if you have skip lesions like this, then you're probably dealing with sarcoid. Granulomatous uveitis can be TB or sarcoid, but if you have VKH, it can also be present and VKH or sympathetic ophthalmia. But one thing with anterior segment where you can pick up probably VKH is if you have a glow like this, in a case of a chronic VKH or a convalescent phase of VKH, where you can have a sunset glow with an orangish glow in the slit lamp itself. The next one is if you have scattered KPs all over. Scattered KPs all over, the first diagnosis should always be fuchs uveitis. But if you have scattered KPs with few pigments here and there, then probably you're dealing with a case of a viral uveitis. Uveitis with raised IOP, scattered KPs, all white stellate polymorphous with diffuse heterochromia, then it's fuchs uveitis. But if it's a segmental iris atrophy and some pigmentations here and there, and if it's bilateral, it can be probably CMV or HSV. If it's in a young female with corneal edema and anisocoria, then you're probably dealing with a case of a Postner-Schlossman syndrome. There are many others. These are glaring at you, a herpes zoster or a lens-induced or a cysticercosis or a JA. One important anterior uveitis presentation where you, in a post-op, a non-uveitic person, when you look at it, is in a intracapsular plaques. If you see in a post-op patient, then you're probably dealing with a late onset end of. Let's see the retinitis and choroiditis. This has been covered quite a bit, and I'll just rush through these things. In retinitis or choroiditis, the pattern recognition is even more important because it's important to differentiate whether it is infective or non-infective. As Soumya was telling in the previous session, choroiditis may be infective or non-infective, but retinitis is almost always infective. So it's important to identify the pattern, match with the known patterns, and look for supportive evidence. So how do you decide whether it is retinitis or choroiditis? When you see something yellow lesion in the fundus, then the key feature is to look for the retinal blood vessel and its relation to the lesion. If the retinal blood vessel is seen very well, then it is probably choroiditis. If it's partly seen and partly not seen, then you're dealing with the case of a retinochoroiditis. If it's not seen at all, then it is retinitis. Why is it important? A retinochoroiditis, the first DD is always toxo. A retinitis is always viral. A retinitis or retinochoroiditis is almost always infective, except in Behçet's. Choroiditis can be infective or inflammatory. So a retinitis when you look at a retinitis, you look at the location. Where is it seen? The shape, the number, and the associated features. The first differential diagnosis of retinitis in a peripheral area, look at the coalescing areas of the retinitis or a scalloped margin. Then you're dealing with a case of a ARN. But it's sometimes the pattern during the course of the disease will also help you make a diagnosis. If you see laser marks all around, or if you have large atrophic breaks or a healing pattern, then that also can be giving an indication whether it was a past case of an ARN. Not always is a retinitis peripheral or coalescing. Sometimes it can be in the posterior pole, or it can be in the periphery but not coalescing. These can also be herpetic if you have supportive evidence in the form of systemic features. This is a central necrotizing herpetic retinopathy. These can be early stages of ARN, which may coalesce later on. Sometimes they can be extensive and coalescing, but not peripheral. This is the typical cracked mud appearance, which is more in the posterior pole, but they are coalescing, but not in the periphery alone. This is seen in HIV and immunocompromised patients. This is PORN, progressive outer retinal necrosis. So, talking of HIV is something where you get so very atypical features and so very characteristic features. You get a typical cracked mud appearance and you get a typical pizza pie appearance, which you can look at it and make a diagnosis of a hemorrhagic CMV retinitis. CMV can also be a granular type of CMV where it may not have too much of hemorrhages. Dr. Padma was talking about CMV retinitis with frosted branch meningitis. Sometimes with moderate and higher counts, CMV can also present with the frosted branch meningitis with inflammation. So CMV is not the only lesion. See, if you have hemorrhages like this, it is probably CMV. But if you have a bleached out appearance like this, then you're probably dealing with a case of a toxoplasmosis. A toxoplasmosis can be focal, multifocal, or diffuse necrotizing retinitis, especially in HIV. But look at the difference. There are hardly any hemorrhages in toxoplasmosis, while in herpetic, there are a lot of hemorrhages, even though this is extensive. So this way you can differentiate probably a toxoplasmosis and a PORN. But when do you suspect toxo in an immunocompetent? Any focal retinitis with local or overall vitreous haze, then you're probably dealing with a case of a toxoplasmosis. Ask for history of contact with pets. So any focal retinochoroiditis with local vitreous haze, you're dealing with toxoplasmosis. Even resolution pattern can be diagnostic sometimes. See, look at the resolution. This is CMV retinitis. CMV is supposed to resolve from center to periphery. The initial part heals first and the periphery heals later. While in toxo, the periphery heals first and the center heals last. So pattern recognition is important not just in the initial diagnosis, even during the resolution or even during the healed pattern. For example, a deep punched out scar, which is typical of toxo. But when none of these patterns look like do not fit into anything, then there are some atypical ones. When it is atypical, which doesn't match with any of this, then you look for some subtle signs. This is Chiariles arteriolitis, which is seen in toxoplasmosis. So atypical lesion, if you have an overlying vitritis with Chiariles, then you're probably dealing with a case of a toxo again. But if you don't get into any of the subtle signs also, then one thing you need to almost always rule out is syphilis. Syphilis can present with atypical retinitis, vasculitis, placoid lesions, or saltpeter retinopathy, or like this. If these precipitates are there, then it's almost diagnostic of syphilis, especially if there is suggestive history. Currently, with so much of epidemic retinitis, fever-associated retinitis, Dr. Padma has already spoken, but one infection which is omnipresent other than God is probably COVID. Choroiditis, Basu is already covered. Choroiditis can be infective or not infective. A solitary nodule, if it's more orangish, it's a very vague way of diagnosing, but a more deeper lesion and orangish lesion can be sarcoid. A more yellow lesion is usually tuberculosis. White dot syndromes can have a lot of patterns, but the most important thing, the common ones which we see here, I'll just rush through the last slides. Multiple choroidal lesions, if they are there, then you look for the pattern. If they're placoid and discrete, it's APMPP. If they are partly coalesced and partly not coalesced, then you're probably dealing with a case of an amphigenous choroiditis. This amphigenous or a serpiginous, if it is a snake-like pattern starting from the disc, it's a classical serpiginous and which is usually autoimmune. If it's coalesced snake-like, not starting from the disc, but from the mid-periphery, along with vitritis or vasculitis, then probably you're dealing with a case of a tuberculosis or a serpiginous like choroiditis. So the White dot syndromes can be many, but the common ones can be the multifocal choroiditis, APMPP, or the serpiginous or a serpiginous-like choroiditis. Always rule out pseudo-uveitis. CSR is one thing that, as it was pointed out, is one thing where FFA is such a helpful diagnostic tool to diagnose lymphoma, ARMD, and other things. Intermediate uveitis, don't miss out on a snow banking, don't miss out on a multiple sclerosis or a lymphoma, considering it as intermediate uveitis. When in doubt, image or intraocular specimen evaluation. So, pattern recognition for diagnosis, identify the pattern, see if it is indicative of any of the known patterns, look for some supportive evidence, investigate and confirm, image if required. But it's important that you rule out imitations. Imitation is something that is happening quite often, and intraocular specimen evaluation whenever it's required. So probably this you can call, if the eye and the toolkit comes together, doesn't mean I'm political. No politics, please. Thank you.
Thank you. So I want to add one sentence. Can I do that?
Yes, sir.
May. So actually, in real life situation, the disease doesn't read textbooks. So even if you see some classic pattern, many of the times it will not fit to a particular diagnosis. In that case, what I do is that I closely follow up the patient, or that's next day we'll see that one. That will be re-evaluating that one if it doesn't fit with your laboratory investigation. Second thing I do is that send the photo to my senior, like Professor Amod Gupta or Dr. Narsingh Rao, my teachers. Or if I don't do that one, ask my junior colleagues also to see. So that's one of the things, is don't hesitate to take another opinion if it doesn't fit with the textbook pattern.
Right. Thank you for those pearls of wisdom, sir. We'll go on to the next talk by Dr. Mayur Morekar. Dr. Mayur is an associate professor of ophthalmology at Bombay Hospital Institute of Medical Sciences in Mumbai.
Samyak, can I interrupt you for a second?
Sure, madam. Sure.
So I would like to pay my respect to Dr. Biswas sir, and I'm sorry to interrupt, but I couldn't help myself. Awards do not make a person, and he's one of the greatest teachers. But here on this platform, we would really like to thank him for being such a wonderful teacher and then congratulate him. Dr. Lahani sir is going to join us after his talk, but I couldn't help myself just to say thank you for being the greatest teacher. And awards definitely do not make you, sir, but for the beautiful award that the AIOS has conferred upon you, sir. Pranam, sir.
Oh, no mention this. Thank you. It's too embarrassing.
Oh, so sorry to interrupt, Samyak. So sorry.
No
and Sir Biswas, sir, sorry for interrupting your session, sir.
Thank you. Thank you very much. Very kind of you.
Thank you, Dr. Sudarshan, sir. That was wonderful and beautiful.
Thank you.
Thank you, madam.
Sorry, Samyak, all yours.
No problem. Thank you, ma'am. Dr. Mayur, can you please share your screen?
Yeah, can you see it, Samyak?
Yes, you can see it. Yeah.
Yeah, so what I'm going to do is, in the interest of time, I'm going to run through this a little fast.
Sure.
And with acknowledgements to my teachers, as always, the topic for today is immunomodulation in pediatric posterior scleritis. These are the key learning points, and we'll come back to this slide later. We are going to arrive to those key learning points using the case of a 12-year-old boy who presented to us in April 2019 with a 1-year history of drooping of the left eyelid, an ESR which was raised, a CRP which was raised, 2 MRIs done, one in February 2018, one in June 2018, both reported as orbital pseudotumor. This is his presentation to us. You can see a congestion of the conjunctiva and a congestion of the episclera. We did a fundus examination. I haven't put the image here because I don't have it. There were no vitreous cells, no vitritis. He had a mild disc hyperemia with a pocket of subretinal fluid between the disc and the fovea, which prompted us to think of posterior scleritis and do this B scan, where you can see the thickening of the choroid, the T sign, and the fluid in the subtenon space. You can see the elevation of the retina here, which is present in this OCT scan as well. We then got his old MRI re-reported, which showed enhancement at the posterior margin of the left globe. there was a hyper enhancement of the left superior rectus, the lateral rectus, and the left lacrimal gland. Probably that is why it was reported as a pseudo tumor. We repeated his routine investigations, including ACE, ANCA, TSH, antithyroid antibodies, serum uric acid, which were all negative. A Mantoux test was done, which was negative. The serum IgG4 and ANA were all normal. And since the patient had an active posterior scleritis, we escalated the already present dose of 15 milligrams of oral prednisolone to 25 milligrams. We then made a rheumatology reference requesting the rheumatologist to start him with oral methotrexate after ruling out systemic tuberculosis, which the rheumatologist did. And with an impression of posterior scleritis, he was started on oral methotrexate at 15 milligram per week on the 13th of April, which was then escalated after 8 doses to 20 milligram per week. By the 20th of May, this is May, by the 19th of November, that is roughly about 7 months post starting him on methotrexate, we were able to taper down the steroid dose to 2.5 milligram of oral prednisolone, but it never happened that we were able to stop the oral steroids because multiple attempts to do so kept on relapsing the inflammation, and therefore we had a maintenance dose of 5 milligrams per day, and we further kept making attempts to taper and stop steroids. By 13th of February 2020, he was at 1.25 milligrams of oral prednisolone, at which time he presented to our emergency services with a severe relapse. And apart from the signs of posterior scleritis that you can see here in the form of a disc hyperemia, these retinal folds, he also had a severe lateral rectus inflammation, which made us escalate the steroids back to 20 milligrams per day. We then requested the rheumatologist to escalate methotrexate further. He took it to 25 milligrams per week. And after 5 doses of methotrexate at 25 milligrams per week, we realized that methotrexate was probably not the drug of choice for him, and therefore we stopped the methotrexate. By now, we knew that the clinical impression, apart from the posterior scleritis, was also an associated orbital myositis, and therefore the boy was started on oral azathioprine, initially at 75 milligrams per day, which was later escalated to 100 milligrams per day. The oral prednisolone was then slowly tapered, and by July 2020, that's about 3 months after starting him on oral azathioprine, we were able to stop the oral steroid. By August 2020, he came back to us with these skin lesions. This is the right axilla, this is his chest, and this is his back. This is the shoulder part of his back. We did a dermatology reference where he was initially diagnosed to have this entity called hidradenitis suppurativa, for which he was initially started on oral isotretinoin along with oral azathioprine and oral clindamycin and topical medications. By August 2020, we realized that his dermatology diagnosis was something that is called PAPA-SH syndrome. This is what PAPA-SH syndrome is. It's a syndrome which involves pyogenic arthritis, pyoderma gangrenosum, acne, and suppurativa hidradenitis. In September 2020, he had finished a cumulative dose of isotretinoin of 1,760, whereas the target dose was 6,720. He had been on oral azathioprine 100 milligrams per day, and he was off all eye drops by the 17th of November 2020. In his last follow-up visit on 15th of May 2021, that is about a week back, 2 years on treatment, we have been able to have a comfortable patient, eye and the skin, 20/20 vision, no disc edema. He is now on oral azathioprine 100 milligrams per day since almost a year. He's on oral isotretinoin 20 milligrams per day with calcium and folic acid supplements. We almost have 9 months since the cessation of oral steroids, and we have about 6 months since cessation of topical steroids. Coming to a little of the literature review, Dr. J.B. Sir's patient on the clinical profile of scleritis in children, where posterior scleritis is the most common subtype of scleritis, 41.7%, and tuberculosis is the only systemic association which they found in 3 patients. Orbital myositis can be associated with scleritis, and when myositis and scleritis associated, it is most often with posterior scleritis. Inflammatory eye disease can be associated with our diagnosis of hidradenitis suppurativa, and in a series of 24 patients of this diagnosis, roughly 13 patients had inflammatory eye disease, 6 of which was scleritis. And it is found that management of inflammatory eye disease, which when associated with hidradenitis suppurativa, requires systemic immunosuppressive treatment in 70% of the patient. Finally, coming to our main syndrome, the PAPASH syndrome, it is basically a disease in which there can be extracutaneous site involvement and affection of the eyes in the form of scleritis. So coming to the key learning points from this, a high index of suspicion has to be kept in mind for a diagnosis of posterior scleritis. The role of the USG-B scan, the key sign in the diagnosis of posterior scleritis, is all important. There's always a need for involvement of a good pediatric rheumatologist in the management of posterior scleritis in children, as immunomodulation will be required, and as evidenced in this case, we may require change in immunomodulatory treatment in the middle of the disease. One of the biggest key learning points for me from this case, that when you are immunomodulating the child, the aim of treatment is to be able to get the child off oral steroids. And like in this case, we took about a year, but we were able to take him off oral steroids, and now he's completely been off oral steroids for almost a year. And of course, systemic associations in pediatric scleritis, although rare, one needs to keep searching, and especially when we have manifestations in some other organ system, try to look for a systemic association like we have in our case. Thank you.
This case shows how a multi-specialty consultations helps in the clinching a diagnosis. Sometimes you have to keep the eye open, and not to see the patients in the dark room only. We need to keep the patient as a whole. We have to look at the patient, and then we can make a lot of simple or as well as the rare diagnosis.
Can we move on to the next speaker?
Yes.
The next speaker is my teacher, Dr. Somshila Murthy. She, as we all know, requires no introduction. Currently the member of the scientific committee of AIOS, the head of cornea anterior segment services, and a consultant in the uveitis services at the L.V. Prasad Eye Institute, Hyderabad. Welcome, Dr. Somshila.
Thank you very much, Mayur. And it was a pleasure listening to your very interesting cases and great management of that case. So thank you. And thanks to the organizers for giving me this opportunity once again in this meeting. I'm going to, of course, talk about my favorite subject, that's scleritis. If anybody is expecting something better than what Sudarshan did, then I'll be disappointing, because while he presented an excellent helicopter view, so mine is going to be very specific. I'm just going to go into a few specific details to try and wrap up within 10 minutes. So I thought this is a very intelligent way of looking at any disease. So because a lot of these patients come with similar patterns, and I think if we can learn the pattern, we can be wiser and we'll know exactly how to treat these patients. So always I go to this particular classification system, which divides scleritis, non-infectious scleritis as anterior and posterior, and then you have necrotizing and non-necrotizing, and the various entities within them. Also remember, on the hovering around them are infectious scleritis. You can have masquerade. Sometimes you can have scleritis which actually is not and turns out to be a masquerade. Sometimes you can have true scleritis occurring in a patient who has a tumor. So those kind of entities would exist. And you can also have surgically induced scleritis. So the pattern for the first part we need to recognize is how to differentiate episcleritis versus scleritis. I'm sure for all the very seasoned uveitis specialists and inflammation specialists, there's not a problem at all. But when you're starting out, or perhaps for general ophthalmologists who may not be seeing that many cases, this becomes very challenging, because the patients present with a very dramatic looking red lesion, like this particular patient here with a nodule. So you have to use the pattern of what is the history. Does the patient have any systemic disease? and especially what is the pain component of this disease. So in episcleritis, they'll typically not have pain, but more of tenderness or foreign body sensation. And they would have come because their family or somebody else has noted the redness. And for me, it always works to do blanching with phenylephrine because that will blanch out most of the vessels and you can see exactly where you are. So there's one patient who has multiple episodes and you're not exactly sure. He says, yes, he has pain, but when you apply phenylephrine, you see that most of the vessels, except the one large prominent vessel, disappears. And so you're very confident in saying that this is a case of episcleritis. On the other hand, you know that scleral inflammation, both the superficial and deeper layers, would show edema. And instead of seeing a very bright crimson red kind of pattern, you'll see a very blue, deepish kind of a violaceous pattern of the congestion that you notice. So this is the pattern that you have for scleritis. So what are the various ways in which we should examine? As Sudarshan said, so examination is one of the hallmarks apart from history taking. And we don't put the patient directly on the slit lamp, but always examine in daylight or in clinic light actually, or put a torchlight and examine the patient. And also don't examine just the central view what the patient is looking at you, but make the patient look in all directions of gaze to uncover exactly the extent. So those are the patient, if I just look at just the central view, I would barely notice that there are a lot of dilated vessels. The patient does have classic symptoms. So I go on to evaluate all areas and I notice that the patient has diffuse scleritis, which required long-term systemic immunomodulation for this patient. If a patient walks into the clinic like this, so whether it's a general ophthalmologist or a resident or anybody can make the diagnosis. So this kind of examination is very easy. You'd say that the patient has nodular scleritis with activity, as well as perhaps old episodes which have now healed and become a ciliary staphyloma. So this kind of pattern you may in the general clinic not see as often, but if you see it, it's very easy to make the diagnosis. The next part after examining on just a direct illumination is to see on the slit lamp. So what's the utility of the slit lamp is that, so you can once again differentiate between nodular scleritis versus episcleritis. In scleritis, this is one thing I've noticed, that the anterior part of the slit is very well discerned, obviously, but you cannot really make out the posterior extent because there's a deeper edema. And in some of the episcleritis, you can actually see the translucent posterior part of the slit as well. The red-free filter is very useful in delineating areas which here it may look like that this is an inactive area, whereas there's activity adjacent to it, but actually it's not inactive, it's an area of capillary dropout, so previous episode. So this is also ruling in the diagnosis of scleritis. So these are various kind of typical scleritis that you might see. You might see diffuse anterior scleritis with engorged vessels. Sometimes there's an inflammation maybe a little close to the limbus, and you might see some suspicious looking limbal lesions, or when there's early corneal involvement. When you look at this bluish region over here, it does not immediately put the patient into necrotizing scleritis category. But because the patient had diffuse anterior scleritis, maybe something like this, when the scleritis resolves, the scleral thinning of the fibers make the bluish hue of the uvea visible over here. You can also notice that there's some peripheral corneal opacification. That was because in the past, when the patient had activity, there would have been peripheral corneal infiltration as well. And sometimes, though we say non-necrotizing, but you see these ischemic areas which are undergoing destruction. This is also diffuse anterior scleritis with peripheral corneal involvement as well. And these are not infective foci, but they are necrotic areas in the watershed regions. So it can be confusing between infectious and non-infectious in the nodular variant. And these are all cases of immune-mediated nodular scleritis, but they have these ischemic looking infiltrates, which are sometimes, they closely mimic pus points, but they're not pus points. And really there's no way but a pattern recognition for you to make out. Earlier I would scrape them and try to see if they had any microorganisms. So when you apply the red-free filter, you notice that the blood vessels just absolutely stop short of this area, suggesting that it is basically a capillary dropout or a vessel dropout. Whenever you have patients with corneal involvement, think about top 3 diseases that you can think about. One is, of course, this particular patient had relapsing polychondritis. That is very rare. You may not come across it very often, hopefully. But this patient had a diffuse anterior scleritis as well as peripheral corneal infiltrates and went on to have multiple episodes over years and years. Also, the patient shows typical saddle nose deformity, which helped rule in the diagnosis. And the patient was ultimately stabilized with the help of biologics and subsequently with tocilizumab. So this is what you can have when you have corneal involvement. Search for your investigation will be directed towards looking for a systemic immune-mediated disorder. This was another case who came in reverse. The patient already is diagnosed with full-blown granulomatosis polyangiitis, formerly known as Wegener's, and comes in with active scleritis as well as peripheral corneal involvement. Do not rush to do a patch graft for this kind of patient. When you immunosuppress the patient adequately over a period of time, what looks very scary and frightening actually resolves to become a very stable anterior staphyloma, and the eye gets quiet when the disease gets quiet. So don't forget to examine the patient. Sometimes they may or may not give you history. You might see these are not from my patients, but from the books, and you might see this deformity, or you might see an effusion in the ankle. And these patients may well have something called, for this patient actually has this lesion, scleromalacia perforans, which is a very low grade immune mediated scleritis that is happening for these patients. So posterior scleritis is another entity altogether, in the sense that patient will come in with some decreased vision, but nothing really much anteriorly. This has been very well documented in the textbooks, that they will barely have any symptoms anteriorly because the disease is directed posterior, the scleritis is posterior. How do you pick it up? You basically would do a B scan. You have to suspect it, of course, in order to pick it up. So the patient will have symptoms out of proportion to the signs that you see in the anterior segment. And the B scan will elucidate the T sign, which is the presence of fluid in the subclinical space, for you to come to a conclusive diagnosis. Coming a little bit about infectious scleritis and the pattern recognition. So how do you make out that it's infectious versus immune mediated? For example, this patient does give history of wooden stick injury. And although we shouldn't jump directly to fungal keratitis, but this patient had the stereotypical fungal keratitis. So the same patient has a necrotic lesion here, which is healing because the treatment was started for the patient. And the same patient has another lesion totally disconnected and away from the primary lesion. So this is a pattern you see in infectious scleritis, whether it's fungal or even other agents. This is another patient who had undergone pars plana vitrectomy and was being treated as surgically induced necrotizing scleritis because of this clinical picture. But the pattern to recognize here is the presence of slough at the base of these ports. And another pattern was that the patient did not improve at all with oral steroids. So look carefully. We had actually sent this for scraping and we got no cardia in this particular patient. So whenever you have post-trauma as well as surgical, think first whether it could be infectious or not, especially if you see some debris or some slough or a non-improvement with oral immunomodulators. So we had this patient who was clear, obviously a case of infectious keratitis, was fungal with the perforation, but was referred to us because they thought that the patient also has scleritis. So there was nothing but this patient had undergone pterygium surgery actually and was initially treated as surgically induced necrotizing scleritis with a lot of steroids, and then developed fungal keratitis as well as scleritis. So this pattern is fairly clear to make out, but sometimes this can confuse a clinician, especially if it's a recently operated patient. Another pattern we see very often for infected scleritis is multiloculated or multiple pus points. In this particular patient, this was also after surgery. The patient had a traumatic cataract surgery requiring ACIOL, and the patient had subsequently pars plana vitrectomy, multiple interventions, and eventually developed infectious scleritis unrelated to the surgery, and this turned out to be no cardiac. Rarer patterns that you may see include patients with very chronic, indolent, waxing and waning kind of history. This particular child had it for almost 1 year, and this lesion kept growing from a very tiny entity. Ultimately, we did an incision. We did an incision biopsy from this lesion. Turned out to be Mycobacterium tuberculosis, and the patient could improve with ATT. Another patient, an older individual, 35-year-old with a 5-month history, developed a scleral nodule, and we did an excision biopsy. Turned out to be M. leprae. The patient also, luckily for us, we could diagnose, had features of Hansen's disease systemically. So the last lesion I would like to discuss is about viral etiology. So this is not as uncommon as you would think. And of course, you need to suspect that. There was a patient who had 2-month history of pain and redness. This was supposed to be immune-mediated scleritis. And the patient was started on oral steroids. There was no improvement. And when we asked history again, then the patient said, yes, he did have rash on the forehead. And you can also carefully look at the nummular lesions on the cornea. So whenever you have lesions on the cornea like this, with scleritis, then you assume that it must be viral scleritis, and the patient improved rapidly after we started the patient on oral acyclovir. So the last part is, yes, you can have masquerades. This is not scleritis, but initially, maybe because of the appearance of this lesion, it looked just like nodular scleritis. The patient kept on undergoing therapy, also was a little non-compliant. So the patient was put on immunomodulators and so on. Ultimately, developed a lot of complications, and the tectonicity of the eye could not be maintained, underwent evisceration once it was recognized that there was an ocular surface squamous neoplasia. So this patient initially presented what looked like exactly like a nodular scleritis, but subsequently worsened and turned out to be an ocular masquerade with OSSN. So to conclude, pattern recognition can help us differentiate various types of scleritis. More important, we can streamline our investigations, whether it's infectious or non-infectious, or if it's non-infectious. So should we investigate more to look for systemic etiology, as I mentioned earlier? And therefore, obviously, that will help us formulate our management strategies. So this was just a primer, and there's lots more coming up. I'd invite you to attend this meeting next weekend. You can do that after the BOA for that day meeting gets over. And this is all about scleritis. Further secrets will be unraveled at that meeting. We have a wonderful lineup of international and national faculty. Thank you very much.
Just one comment I want to make.
Yes,
the
sir.
scleritis patients, if it is not responding, and then don't hesitate to, as you have told mind correctly, don't hesitate to take a snip of the tissues, particularly is the limbal involvement to rule out a muscular syndrome or infectious scleritis.
Yes, sir.
So that's the very important point you stress.
Sir, Jyotirmay Biswas, sir, thank you very much.
Thank you, sir. Thank you,
sir. I want to congratulate you for the very coveted award of the BK Narendra Award by the All India Ophthalmic Association bestowed on you, and you deserve more than you. But yes, I really congratulate from bottom of my heart, and I'm very proud of you. Thank you very much, sir, for joining. As our own Nikhil, Mayur, Hitesh, Samayak, they have joined. Also the Swapnil, Nikhil, this Sudarshan, and then the Mayur, Shamshula, just now I was hearing you. It was a very nice talk. Then the Rima, Amitabh, and sir, lastly, he is going to speak. I welcome you all for the Bombay Ophthalmic and Maharashtra Ophthalmic Association conference here. And sir, thank you very much for making it to come here. Thank you, sir.
Thank you very much. Grateful. Very grateful. It's an honor for us.
Thank you, sir. Thank you very much.
Beautiful, Somashila, as usual.
Thank you, Dr. Ragini.
Thank you, sir and madam. Thank you, ma'am. Dr. Somashila.
Samyak has been.
I'm sorry, you're muted, ma'am. Dr. Ragini, you're on mute. Sorry, so I think we missed that. Thank you, Dr. Somashila. It's my pleasure to now to invite Dr. Rima Bansal. She's an additional professor at Advanced Eye Center, PGI Chandigarh. She has multiple publications to her credit, chapters in textbooks, and many awards. And she is also on the editorial board of in the Indian Journal of Ophthalmology and Ocular Immunology and Inflammation. She's also my teacher from PGI Chandigarh. Welcome, ma'am.
Thank you, Samyak, and many thanks to the Bombay Ophthalmic Association and Maharashtra Ophthalmic Association for inviting me to talk on endogenous endophthalmitis. And before that, Dr. Biswas, sir, many regards and many congratulations to you.
No, thank you.
Are the slides visible?
No, you have to click
They're
on
not yet open. Yeah, but we can see your screen.
Can you see me?
No, you have to click on that.
Is it displayed?
No, the slides are not displayed, but we can see your screen. So you probably have to click once again. Yes.
Yeah.
Might have shared just the browser, not the PPT.
Is it okay now? No.
No.
You'll have to share the PPT, the PowerPoint. You might have shared only the search folder.
All right.
Try stop this screen sharing and try it again.
Yes, you can open the PPT and now share the screen. Yes.
Yeah, it's come.
Yes.
You know, endogenous endophthalmitis is an ophthalmic emergency, also known as metastatic endophthalmitis, because it has severe sight-threatening complications with various underlying predisposing factors. And the microorganisms causing endogenous endophthalmitis have a very broad spectrum. Now, the definition exactly is it's an intraocular infection affecting the inner coats of the eye associated with significant progressive vitreous inflammation, enough to give it a term of endophthalmitis. It is caused by hematogenous spread of microorganisms from a distant focus in the body. And the hallmark of this is a very significant involvement of the vitreous cavity. And endogenous endophthalmitis accounts for approximately 2 to 8% of all cases of endophthalmitis. Now, both bacterial and fungal agents can be the potential agents. It also depends on the geographical location. Like in developed countries, you mostly have gram-positive, and in Asian, you have gram-negative. But here in our scenario, fungal organisms account for majority of the cases. So we know there are a lot of predisposing factors, and these play a very important role when we are seeing these patients in terms of eliciting the history. So we need to know the history in terms of any recent hospitalization, an underlying diabetes mellitus, history of UTI, whether the patient is immunocompetent or immunosuppressed, is there any underlying malignancy, is he or she on any immunosuppressants, any neutropenia or HIV, any history of intravenous drug abuse, indwelling catheters, any history of liver abscesses, especially Klebsiella pneumonia, any association with infective endocarditis. And we see quite a lot of pediatric patients, neonatal endogenous endophthalmitis in the ROP babies, in low birth weight babies with candidemia and bacteremias. So I'll take you through a couple of cases. This is a young woman who presented to us with decreased vision in the left eye for since 1 week, and she had hand motions vision. So you can see the pupil is well dilating, no synecdoche, but you have a hypopyon. And when you dilate and see the fundus, you just see a yellow glow. So this is the comparison with the other eye. The right eye was normal, and all that you could see in the left eye was this yellow glow. The ultrasound showed a lot of exudates filling the vitreous cavity. And when it comes to history, she had history of typhoid fever a month ago for which she was treated elsewhere. She, of course, received IV medications and IV fluids and developed ocular symptoms 3 weeks later than this episode. So as part of an initial treatment, we treat these patients as an ophthalmic emergency, and we admit them, immediately start them on IV ciprofloxacin. We send their blood and urine cultures and get their underlying status checked in terms of diabetes, complete blood counts, X-ray chest and renal liver function tests, and history of HIV. We take up these patients for a pars plana vitrectomy, both for diagnostic and therapeutic purposes as soon as possible. And this is what we did for this patient, along with injection of Vanco and Cefta. And since the patient had hypopyon, we start broad spectrum antibiotics along with anti-inflammatory and cycloplegics. So the microbiology report was very instant. We had some gram-positive cocci, but the KOH smear is the fastest that you can get, and this showed septate hyphae. So we started the patient on antifungal, itraconazole. The cytology, we make sure that we send a sample to cytology also, because we may not have any growth on the culture, which is quite common. So cytology showed some lymphocytes, polymorphs, and degenerated cells, and numerous septate fungal hyphae. Features were overall suggestive of fungal infection. We got the fungal PCR done, which was positive. And so we made a diagnosis of fungal endogenous endophthalmitis in this case. So just to highlight that Professor Amod Gupta sir pointed this factor as a very important causative agent for causing endophthalmitis, endogenous endophthalmitis in immunocompetent patients. And this was a single IV infusion, presumably a contaminated dextrose infusion fluid, which was found to be a new risk factor for developing endogenous endophthalmitis way back in 2000. And now we have evidence almost every day from these as a risk factor. So after operating this patient, you can see the hypopyon on the next day has disappeared. And this is primarily because of the topical anti-inflammatory that we have started, and also because of debulking of the vitreous cavity. But the fundus really did not show much improvement in terms of the glow. And now that we had an evidence of fungal endophthalmitis, we switched from vancomycin to intravitreal amphotericin and dexamethasone. And you can repeat this in the dose of 5 micrograms. On day 4 and 6, we repeated this. And this is how, you can see the glow improving. You can see a partial view of the fundus coming back. You can see the optic disc. And by day 10, still there was some lot of vitreous debris. So we took up this patient again for a therapeutic vitrectomy just to clear the vitreous this time, and continuing with the intravitreal amphodexa. So she improved on post-op day 1. You can see the retina, and you can see a nice lesion at the macula, which is very characteristic of, you can see subretinal exudates over the macula, very characteristic of this fungal endophthalmitis. And when we talk of fungal, we need to know whether it's Candida or Aspergillus. So there are some clues which help us to differentiate between them. Predisposing factors we see more in case of Aspergillus when we're dealing with immunosuppressed patients or organ transplants, and Candida more after following a past GI surgery. Systemic risk factor, diabetes predisposes to Candida, and leukopenia to Aspergillus. Coming to clinical presentation, you have large focus of deep retinal necrosis or a chorioretinitis, especially in the macula, as we saw in the previous case. And when it comes to Candida, we see more of the fungal exudates in the vitreous cavity. The type of inflammation both have acute. Vitreous culture may be negative in Aspergillus, but a higher yield in Candida we get. Vascular invasion is much more common with Aspergillus and not really there with the Candida endophthalmitis. Prognosis is extremely poor in Aspergillus because of the direct involvement of the macula. So this was our center's experience of all fungal endophthalmitis from 91 to 2005. Of 113 patients, majority of them were post-cataract surgery and post-trauma, followed by endogenous endophthalmitis. And as we can see, the fungi, Aspergillus dominates them all. So second case is a bit different, was not as robust as the first case. So we had this 43-year-old male presenting with decreased vision in the left eye for 5 days, counting fingers vision. And you can see the right eye is normal and there is a coin-shaped lesion at the fovea, almost a little smaller than the disc size. So this is the enlarged view, and this was a very focal, localized lesion in the fovea. And this time we were not sure of whether we're dealing with an exudate or a retinitis or a chorioretinitis or maybe a membrane. We're not sure. So we did in fluorescein angiography, which was not really very contributory. We just saw some kind of hyperfluorescence in the end. The OCT gave us a clue that this was a full thickness lesion coming from behind and almost invading the vitreous cavity. Now, on past history, this patient did have history of high-grade fever with chills, with cough, with expectoration a month ago, and he was a diagnosed case of swine flu and had bilateral pneumonitis. He was also a known diabetic. The reports that he already had with him showed deranged platelets and high sugars. HRCT showed pneumonitis, and his throat swab was positive for H1N1. Now, since influenza is known to cause retinitis, although the ocular manifestations are very rare, but retinitis is among one of them. And all these retinitis like dengue and influenza are known to respond to steroids. We started oral steroid in this patient. And to our disappointment, at 5 days, you can see the one on the left is the baseline, and on the one on the right is at 5 days. He has worsened. The lesion has increased both in volume, in size, in dimensions, and this is the OCT. On top is the baseline, on bottom is at 5 days. Now you can see the lesion has not only infiltrated the vitreous cavity, it's expanding horizontally above the vitreous, above the ileum, on the retinal surface. There is increased reaction in the vitreous cavity, and of course it is extending even subretinally. So we took up the patient immediately for a diagnostic and therapeutic PPV. Although the vitreous was very clear, we went very near the fovea, lifted up these exudates lying on the retinal surface, aspirated them and sent them for KOH and culture. And KOH revealed septate branching hyphae. Pan-fungal PCR was positive, and blast analysis showed Candida albicans. So this was a stage when the patient presented to us, fungal chorioretinitis without much of vitreous invasion, although it had started. With our steroids, we made it to progress to fungal chorioretinitis with vitreous invasion, stage 2. And then a vitrectomy halted the progression of this lesion. We aspirated the exudates on the retinal surface, gave him antifungal therapy along with intravitreal, and the lesion healed, and you can see at 2 months he's healing. So we published this as a case report of fungal retinitis as an early sign of endogenous endophthalmitis following H1N1 infection. So coming to the clinical stages of fungal endogenous endophthalmitis, you have the first stage of chorioretinitis, where you have chorioretinal changes without extension into the vitreous cavity. And then you have chorioretinal fungal mass penetrating through the ILM into the vitreous cavity. And then you have extensive vitreous infection, where you have the entire vitreous involved, and stage 3 along with an associated retinal detachment. So case 3, these are some of the difficult challenges, and you may have a mixed infection and challenges in presentation as well as management. So we had again this another 43-year-old male who was a known case of cutaneous malignant melanoma post 3 cycles of chemotherapy, had a sudden onset of loss of vision in both the eyes, left eye more than the right eye. Now look at the clinical picture. Right eye hand motions, you have fibrin, you have hypopyon. Left eye light perception, there is proptosis, there is lid edema, chemosis, hypopyon. Pupil is not dilating. So when it comes to endogenous endophthalmitis, right eye, yes. Left eye is not very typical of that, along with restricted movements. So what were we dealing with? He was an immunosuppressed patient with chemotherapy, known case of cutaneous malignant melanoma. So to say, we wanted to have a look at the right eye more seriously because we thought this is more salvageable eye. So we took up this patient for diagnostic vitrectomy in the right eye. And you can see immediately post-op, there is resolution of the fibrin and hypopyon. Pupil is very well dilating. Fundus, we had started to see after vitrectomy. And this is the progress. He was doing fine in the right eye and gained counting finger 3 meter vision. And we had started to see the fundus in the right eye. You can see the exudates resolving, and he was doing fine in terms of in the right eye. Now, what happened to the left eye? We couldn't really do much because he was it metastasis in the left eye? Because the clinical picture was not very consistent with the endophthalmitis. So the left eye, all that we could do, because we had started IV antibiotics and all that, we were getting the patient ready for a PET CT. And meanwhile, his proptosis was decreasing, chemosis was decreasing, and the anterior segment was just, we are not able to see anything. So the PET CT revealed that he had metastasis almost in every part of the body, including the left choroid. So you can see hyperintense lesions in the increased FDG uptake in the left eye. So this was actually a case of an endogenous endophthalmitis in the right eye, although we didn't get any cultures positive, but he did respond to IV antibiotics, broad spectrum, and vitrectomy. And left eye went ultimately into a phthisis because he had this malignant invasion into the left eye. So we referred the patient back to the for chemo, and this was the progress in the left eye, that he was deteriorating. Obviously, we couldn't save this eye. So this was how he presented to us, and this is how he went on a follow-up, and then he went to the for chemotherapy. So coming to the various drugs that we use, I'll just put 2-3 slides on this. Amphotericin B, we know the penetration of systemically administered antifungal agents is variable. And coming to Ampho, it has a poor concentration into the vitreous and also has systemic toxicity. And that is the reason we prefer it for an intravitreal injection. So it has acts as a very good adjunct along with other systemic drugs. Fluconazole, the vitreous concentrations are much more, and almost 70% of those in the plasma. Intravitreal injections are well tolerated, but usually they're not given because the vitreous levels are achieved high enough with oral drugs. Very effective for Candida endophthalmitis, and itraconazole is effective for Aspergillus endophthalmitis. Voriconazole, now we know, most promising with broad antifungal activity. Therapeutic concentrations for most of the Candida and Aspergillus species are achieved in the vitreous. The intravitreal injection provides a very immediately high level of the drug in the vitreous. It also has an added advantage over fluconazole in the sense that it has activity against Aspergillus species and fluconazole-resistant Candida species. So treatment, when it comes to Candida chorioretinitis with no vitreal involvement, oral fluconazole or voriconazole. When it comes to Candida chorioretinitis with vitritis and all cases of Aspergillus, systemic therapy along with intravitreal ampho or voriconazole. Ampho has a longer half-life after intravitreal injection. So just for you to go through a quick reference in the IGO 2019 June issue for endogenous endophthalmitis in children and adolescents, a very nice article, which we all must go through. So I'm not putting the details because of the limitation of the time. So the key factors to summarize: endogenous endophthalmitis requires a prompt diagnosis and prompt treatment is the key. Systemic therapy and intravitreal antifungal agents do the job, and diagnostic and therapeutic PPV is the treatment of choice in these patients. Thank you very much.
I'd like to make one comment. It's a very nice presentation. There's two conditions where you can get vitritis. One is the acute retinal necrosis in the last stage, later stage, and in case of HLA-B27 pan-uveitis. But never you see yellow glow. That whole vitreous is never hazy. So you can see the retina in any uveitis cases. So this is that one has to be a very high index of suspicion of endogenous endophthalmitis we should keep in the uveitis clinic. Should be referred to the VR people as soon as possible.
Thank you, sir. Thank you, Dr. Rima. We would like to go ahead with the next talk. I'd like to invite Dr. Amitabh Kumar, who's a Senior Consultant Uveitis Services and Deputy Medical Director from Shankar Netralaya, Kolkata, to share the screen and start with his presentation.
Is my screen visible?
Yes, it is.
Good afternoon. I thank the organizers for the invite, and I will be speaking on VKH. And we know that VKH is a bilateral granulomatous pan-uveitis and can be asymmetrical. So since it's a pan-uveitis, you will have a granulomatous anterior segment inflammation, a posterior segment inflammation, involvement of the optic disc in the form of optic disc edema and hyperemia, exudative retinal detachment, and choroidal inflammation. So this is one of my patients who had a pan-uveitis with a disc hyperemia and subretinal fluid in the posterior pole in the right eye and the left eye. We went ahead with investigations, and fluorescein angiography revealed a typical pinpoint leak in the early stages with pooling in the late stages in the right and the left eyes respectively. A swept source OCT revealed multiple locules of subretinal fluid with subretinal fibril. So she was treated with topical steroids and cycloplegics and was also put on 3 doses of intravenous methylprednisolone along with oral steroids and tablet azathioprine. The subretinal fluid resolved after treatment, but she had a couple of recurrences in between, and this is at one of the recurrences when she again had subretinal fluid in the posterior pole in the right and as well as the left eye. So in view of this, she was put on triple agent immunosuppression in the form of oral steroids, azathioprine, and capsule cyclosporine. So this is at the end of around 1.5 years when she stabilized with a 612 N8 vision in the right eye and a 624 N18 in the left eye. So 2 clinical findings which are highly specific to VKH are an exudative retinal detachment in the acute phase and a sunset glow fundus in the chronic phase. Most of the recurrences of VKH are anterior segment inflammation, but the eyes should be imaged at these visits as well because they might have a posterior segment involvement as well. And they will have exudative retinal detachments which are limited to the submacular area. At a study done at Shankar Netralaya, Chennai by J.B. Sir, it was found that the multisystem involvement in our part of the world was only around 37%, and most of the patients responded to oral steroids and immunosuppressives, whereas in the Chinese population, the extraocular signs and symptoms were observed in as high as 85% of the patients, meningismus being the commonest and tinnitus the second most common. VKH also has an HLA association, and people with HLA-DQ1 seem to be protected, but HLA-DQ4 carriers have a higher risk of VKH, and they also elicit raised intraocular levels of inflammatory markers like interleukins and interferon. The diagnostic modalities we have for VKH are fluorescein angiography, indocyanine vein angiography, ultrasonography, optical coherence tomography, ultrasound biomicroscopy, which will reveal ciliary body edema, and of late EDI OCT and OCT angiography. An ultrasound in an acute phase will show thickened choroid, especially in the juxtapapillary region, and also the serous retinal detachment. Angiography shows early pinpoint leaks with late pooling. The ICGA in an acute phase of VKH will show choroidal perfusion delays with hypofluorescent stromal vessels, the HDDs, fuzzy pattern of the stromal vessels, disc hypofluorescence, choroidal folds, and in the late stages, a starry sky pattern. ICGA not only helps us in the diagnosis of VKH, but it may reveal activity despite no clinical or fluorescent angiographic findings in these patients. ICGA can also help us in distinguishing between a choroidal scar and an active lesion. And here you see these HDDs in the macular area before treatment, which have resolved after treatment, but the peripheral ones which have remained are probably the choroidal scars. A non-invasive investigative tool is an optical coherence tomography, which shows hyperreflective dots, the subretinal membranous structures, the retinal detachment, and RPE folds. A swept source OCT is more illustrative, and it shows multiple locules of SRF with choroidal thickening, and also it might reveal choroidal granulomas. So here you see an active phase where there's choroidal thickening and a clear demarcation between the choroid and the sclera, and the lower picture is after treatment. OCTA, on the other hand, has revealed massive impaired perfusion in the Sattler's layer. And if we see on-pass OCT, it shows these foci of choriocapillaris hyperperfusion, which are basically flow deficit areas, and they correspond to the HDDs on ICGA. Treatment, the dictum is to hit it hard and hit it early. And the mainstay of treatment is our oral steroids and immunosuppressants, either in the form of intravenous corticosteroids or parenteral steroids. But immunosuppressive used as a first-line therapy along with steroids in VKH, they have had a superior visual outcome in patients as compared to those where steroids has been used as a monotherapy or with a delayed addition of immunosuppressive therapy. So this is one of the conditions where we would use immunosuppressives along with oral steroids. The immunosuppressives in use are azathioprine, cyclosporin, and mycophenolate. Another important factor is the duration of treatment in VKH, because it's a very recurrent disease. So studies have shown that the acute VKH, they should be treated for at least around 6 months. The local treatments available are intravitreal triamcinolone, intravitreal dexamethasone, but fluocinolone acetonide has not fared well in VKH patients. The possible complications with VKH are cataract, glaucoma, a choroidal neovascular membrane, and a subretinal fibrosis. And this could be a cause of suboptimal vision despite resolution of the inflammation. So in our part of the world, VKH is mainly a probable VKH. It needs a prompt investigations, early diagnosis, and initiation of appropriate therapy for an appropriate period of time, because these patients, they have several recurrences and they need long-term follow-up. Thank you for your patience here.
Very, very nice presentation. I just want to make one comment that you should not allow any VKH, acute VKH cases to go to the chronic phase by putting on the half-hearted approach. You should keep IV, as I told, IV prednisolone, and followed by the immediately oral immunosuppressive and steroid to be continued. So once you go into the chronic phase, you get glaucoma, cataract, subretinal fibrosis, choroidal neovascularizations, all these problems, and the vision is suboptimal. Then the CSR, you should not, multiple bilateral CSR, you should not miss it. That's one of the challenge in case of VKH, particularly even when bullous retinal detachment can be due to the multiple CSR.
Yes. Thank you, Dr. Amitabh. We are overshooting the session, but this is the last talk. I would request respected Dr. JB sir to please share his screen.
I'd like to thank BOA, Bombay Ophthalmic Association, and Maharashtra Ophthalmic Association for giving me this privilege and honor to chair the session and to have the two UVIT sessions. That's as a UVIT specialist, I really admire that you have given importance to that UVITs and giving me an opportunity to share my experience on the management of recent advances in management of UVITs. I'll take exactly 10 minutes time. Is my slides visible?
Yes, sir.
Okay, I'll be talking on recent advances in management of uveitis. I'm not going to talk which is the standard treatment. I'm just going to highlight the advances which has come. Before that, I just want to tell you that what has changed over the years. The laboratory diagnostic techniques like polymerase chain reaction, which has come in the recent last 10 years or 20 years, imaging modality like optical coherence tomography, optical coherence tomographic angiography, and in the radio imaging, the high resolution CT chest in tuberculosis or sarcoidosis, biological agents like infliximab, adalimumab, and we are dealing with the more complex cases of uveitis, like complicated cataract with juvenile idiopathic arthritis associated uveitis, VKH associated uveitis, going to that occlusio pupillae or seclusio pupillae. We can manage this, the complex vitreoretinal surgery, and we are having also intraocular injections like that clindamycin, intraocular clindamycin injection intravitreal, and implants, particularly Ojudex implant. I'm quite optimistic about it. What has not changed is the usage of the corticosteroids, which still remains the mainstay of treatment. We are using also immunosuppressive agents as has been started quite long back in 1960s, and we're still going on that, but we are more familiar, at least in our country, in this part of the country, usage of the immunosuppressive agents, which I'm seeing. So immunosuppressive agents, I just don't want to go into the details of it. There are three categories. There's the anti-metabolites, alkylating agents, immunomodulators. Alkylating agents is little stronger than anti-metabolites, and immunomodulators acts on a much more specific way, targeted therapy, particularly T-cell mediated immune-mediated disease. Their cyclosporine works quite better, VKH, sympathetic ophthalmia, Behçet's disease. So immunosuppressive agents in uveitis, before I thought I'll share my story of a patient, and this patient was from Bihar, and that time there was a Mahabharata was going on in the serial, and then they were playing with a bow and arrow. This patient from Bihar, his brother put the arrow in that with his head, hit the eye, the stem of their coconut tree, that they put that one, and that destroyed the left eye. The right eye was all right, but 1 month after, he lost the vision in the right eye. And he was treated with the local doctors who was given in steroids, but he did not respond. His grandfather brought me to me, and when he is there, this was the vision of that eye fundus pictures. This was taken 20 years back, and then after the treatment with the azathioprine, it becomes completely gone, and the patient get back 6/6 N6 vision from the hand movement. And this patient contacted me through the Facebook and wrote to me that he is doing postdoctoral fellowship at Finland. And this is the patient, then 12-year-old boy, and now is 30 years. This photograph taken with the permission of the patient. So it stimulates me to use the immunosuppressive agents much more frequently. And there are few things I want to tell you, that three important things: when to use it, what to use it, and how to use it. When can you use them? I don't have any doubt that immunosuppressive agents is the drug of choice, or the biologic agents in Behçet's disease. Sympathetic ophthalmia, VKH, right now I put the patients on immunosuppressive agents. As soon as the IV prednisone is over, GI-associated uveitis, methotrexate is my drug of choice. Serpiginous choroiditis, if it is a non-infective, immune-mediated, I put the patients on immunosuppressive agents, even with or without anti-TB treatment. Chronic intermediate uveitis is another condition when I put the patients on immunosuppressive agents, particularly azathioprine or mycophenolate mofetil. Immunosuppressive therapy prerequisite is the absence of infection. If the patient has septic foci, any part of the body, it's not a good idea to put the patients on immunosuppressive therapy before controlling the infection. And there should be reversibility of the disease process. Any eye which has got loss of vision, if we don't foresee that this is a possibility of reversibility, you should not put the patient on immunosuppressive agents. Risk-benefit ratio you have to really weigh. Before starting the immunosuppressive agents, you should know the side effects profile. For example, cyclosporine doesn't produce bone marrow toxicity, bone marrow suppression, but it causes renal damage. Whereas the cyclophosphamide, mycophenolate, azathioprine all cause bone marrow suppression. Cyclosporine, cyclophosphamide more. Cyclophosphamide in addition produces gonadal depression, gonadal dysfunction, and then it's not a drug of choice in case of a person planning for a family. Young adults is not the drug of the choice. Mycophenolate mofetil is the suitable drug, but it has got also hepatotoxicity and very little, but methotrexate and azathioprine has got, particularly methotrexate has got hepatotoxicity in addition to the bone marrow toxicity. So methotrexate patient on methotrexate should have been SGOT, SGPT level done. At least once a month I do it, but you can do it a little longer, textbook says, but to be on the safer side, I put the page, ask the patients to do the liver function test and total WBC and platelet count every month. Sometimes if it doesn't work, we put the patients on combination therapy like cyclosporine, azathioprine and prednisolone. One can combine the azathioprine and mycophenolate mofetil, but that's not a good idea, both that the bone marrow suppression it produces. We have tried the triple agent immunosuppressive therapy in Vogt-Koenigsberg disease and sympathetic ophthalmia, and this showed good response. We have I started using that mycophenolate mofetil quite long back. It is the dose is 500 milligram tablet, 2 times daily initially for 2 to 3 months, subsequently 1 tablet 2 times daily. Control is achieved in all patients. No serious adverse side effects except 2 patients has got viral lesions, herpes zoster lesions in my experience. It's a safe and effective immunomodulator agent, but it's relatively costly. So if you ask me what is the life-threatening risk, systemic steroid versus immunosuppressive agents, steroids is almost nil. Immunosuppressive agents, yes, because that severe bone marrow toxicity can cause to the hypovolemia and you can lose the patient. So periodic follow-up with the investigation as the part the drug is used, like hemogram, liver function test, renal status, physician's review, if there is any side effect occurs. I don't routinely send the patients before immunosuppressive agents to the physicians. I look at the blood parameters and the chest X-ray or high-resolution CT chest, that whether the patient is harboring any infection or not. I myself start immunosuppressive agents many of the times and discontinue the treatment in case of the serious side effects like blood count going, the total WBC count goes below 3000 per cubic millimeter. I stop the immunomodulatory agent. So there's a question now, whether if the patient has got COVID-19, can you put the immunosuppressive agents continue? The rheumatologist experience says that you can continue the immunosuppressive agents who require it. A lot of times you will be also having the COVID-19 patients on immunosuppressive agents. Can they take vaccine? Yes, they can take vaccine, except methotrexate, which has to be stopped for 3 weeks. This is advice from my rheumatologist. Intraocular implants and intravitreal injections has become as a major improvement in the management, is the local treatment. There is 2 implants is there, fluocinolone acetonide and Azudex. And then fluorescein is no longer is that popular because there is not much of difference between the oral therapy versus fluorescein therapy. But it works for 3 years. So we have done the trial with us, 30 patients with chronic non-infectious uveitis. All eyes had reduction of inflammation. But 100% of the patients developed cataract and glaucoma, 40% of the patients, and requiring surgical therapy. And this is the putting the implant is also a surgical procedure, and removing the implant is also a challenge. This is a case which is a VKH patient and which was put on the fluorescein implant was inserted, is implanted, and then there's a post-treatment, there's a complete resolution of inflammation. I'm quite fond of using the Ojudex injection. This is a biodegradable polymer matrix. It's easily been given, and this floats in the vitreous cavity. It's the size of a rice grain, and it has got some side effect is the cataract, which can always take care of it, and glaucoma is about 7% cases. But the glaucoma which it produces is very much treatable with the anti-glaucoma drops itself, medications. So we studied the efficacy of Ojudex implant in the treatment of non-infectious intermediate uveitis. We found particularly the recalcitrant form is responds quite well with the intraocular injection of Ojudex implant. This is the case. So the CME, it works beautifully. Nothing more sure of the treatment that Ojudex implant will work. This is a 20-year-old female, the intermediate uveitis, recurrent macular edema. 9 times thickness was 519 micron in the macular area, foveal thickness. And then one single dose of intravitreal Ojudex injection, it becomes 6/9 vision, and the OCT thickness was reduced to 171 micron. But the patient has got slight intraocular rise of pressure, which is controlled with the anti-glaucoma drops. This is the implant in the vitreous cavity, and it's degrading. What is new is that future therapies, the TNF inhibitors, as well as the several monoclonal antibodies which have been come out, as well as the JAK inhibitors. So there is a list of biological agents is there in the, I'm not going into the details of it. The infliximab is a chimeric monoclonal antibody, other is the human. That infliximab, adalimumab, tocilizumab, and golimumab, these drugs which has got good data with us. And then infliximab is the drug first started, is the dosage is 5 milligram per kilogram of the body weight. First day 1 dose, second weeks 2 doses, and 6 weeks 3rd dose. Infusion repeated in relapses or remission. You have to add methotrexate 7.5 milligram weekly and folic acid 5 milligram daily. But it's a costly medications, is about 1.3 lakhs rupees per month it costs, 3 doses. And this is a case of a base-edge disease is showing so much good improvement of vitritis. As I mentioned to you, these biologic agents has made so much of difference in the management of the non-infectious uveitis. Nowadays, every branches of medicine uses is costly. So why not use the biologic agents, which is a less invasive and quite targeted therapy. Adalimumab is one of the very choiceable biologic agents. It blocks both receptor. Beauty is that you can give a subcutaneous injection and the patient himself can give, or that pharmacist can give that one. Children is a 20 milligram every 2 weeks. It's a USA FDA approved drug for non-infectious intermediate, non-infectious uveitis. So adalimumab there is a lot of data in adalimumab in patients with active non-infectious uveitis. Loading dose is 80 milligram followed by the 40 milligram every 2 weeks. This is less costly, and biosimilars is available, which cost about 12,000 rupees around it. So in base-edge diseases has been found, if you compare with the infliximab and adalimumab, almost the same efficacy, but less complications with adalimumab. JAK inhibitor is the new potential drug, which is the ability to modulate the extent of the cytokine inhibitions. And we don't have experience much with the JAK inhibitor. I don't have any publications, but we have used in a recalcitrant scleritis, and it responded very well. The picture on the left is the before treatment, and after treatment, you can see the scleritis resolved beautifully. So tocilizumab is another interleukin-6 inhibitor, fully humanized antibody, binds both to soluble and membrane-bound interleukin-6. IV infusion is given 8 milligram per kilogram of the body weight at 4 weeks interval. And this is particularly works in the uveitis-related macular edema. Another drug is currently getting tried is the rituximab. So biologics where you stand has emerged as a new weapon in the armamentarium management of non-infectious uveitis. It works base sets and JIA-associated uveitis, but we need more data. Needs precautions before starting therapy, and it's not without side effects. Particularly, it can aggravate a latent tuberculosis, so we should rule out the tuberculosis infection, active tuberculosis infection in the body by doing a CT chest or quantiferon TB gold test. In conclusion, nowadays, with the recent advances, we are more familiar with the usage of immunomodulators. I see prescriptions from everywhere that people are now bold enough to use immunosuppressive agents. Intravitreal Ozurex is drug of choice for me in the uveitis-related CME and the non-infectious intermediate uveitis in particular. Biologics emerged as a new weapon. It is a targeted therapy. It has got systemic side effects less. JAK inhibitor is a new hope, but we have to look for it in the future. Thank you very much. And thank you once again for giving me this opportunity to share my thoughts on recent advances in management of uveitis. Thank you.
Thank you, JB. It was a pleasure listening to you.
Stop sharing, no?
Thank you, sir. I would like to thank everyone for the 2 wonderful uveitis sessions. We did overshoot time. I think I should hand over to Dr. Preetham for the next session on retina. Thank you so much.
Thank you so much. Thank you, Dr.
Thank you. Thank you, Preetham.
Thank you, JB, sir. Thank you, everyone.
It's a really wonderful
Thank you, sir.
to have a session. Thank you. On uveitis, he give the 2 sessions. It's great.
Thank you, sir.
Thank you.
Thank you, sir. Thank you.
So we move on.
Thank you, Biswas sir. Thank you very much. Thank you.
We will move on to our next session. That's diabetic retinopathy. And I invite the chairman of the session, none other than Dr. Lalit Verma.